Hello, everyone. Welcome to our lecture on chronic kidney disease, or CKD, and this is part of our elimination concept. So by the end of this lecture, you should have a pretty solid understanding of what chronic kidney disease is, its pathophysiology, the clinical manifestations we can expect to see in these patients, and nursing considerations and interventions. So let's get started. All right, so we're going to start with a review of some pathophysiology for chronic kidney disease, or CKD. And this is a progressive and irreversible disorder that lasts longer than 3 months. Over time, it impairs the kidney's ability to filter waste as well as maintain fluid and electrolyte balance. And whenever the kidney function becomes too poor to sustain life, then chronic kidney disease advances into end-stage kidney disease or end-stage renal failure. So as we go throughout this lecture, there's a few terms that you need to understand. First is azotemia. And this is the buildup of a nitrogenous waste in the blood. It's often an early indicator of CKD. Next is uremia. And this occurs when azotemia is accompanied by symptoms like fatigue, nausea, or confusion. And lastly, uremic syndrome involves systemic clinical and laboratory manifestations of end-stage kidney disease, which impacts multiple body systems. So again, keep these terms in mind as we go throughout this lecture. They're really key to being able to understand the progression of chronic kidney disease as well as its clinical implications. So now let's take a deeper dive into the different stages of chronic kidney disease, which are classified based on the GFR, or glomerular filtration rate. So this lab reflects how efficiently the kidneys filter waste products from the blood. CKD is going to progress through 5 stages, each with its own unique clinical features and implications for management. So stage 1. This stage has a GFR that is greater than 90, which means the kidneys are functioning within a normal range. However, some abnormal urine findings, structural abnormalities, or some genetic predispositions can indicate kidney disease. At this stage, patients are at risk for kidney damage due to factors like infections, inflammation, dehydration, or conditions like diabetes and high blood pressure. So careful management of these conditions is very important to slow the CKD disease progression. So early intervention here can make a significant difference. In stage 2, the GFR declines to a range of 60 to 89, and this indicates slight nephron damage and albuminuria, or the presence of albumin in the urine, which can be present. So at this stage, there may be slight increases in metabolic waste products, but they're often not enough to cause noticeable symptoms. Increased urine output of dilute urine is possible, which can lead to dehydration if it's not managed appropriately. Stage 3, so this is where the GFR falls to between 30 and 59. And sometimes you may see that this stage is divided into 3A, which is a GFR of 45 to 59, or 3B, which is a GFR of 30 to 44. And this just helps to provide a more accurate risk assessment. So at stage 3, nephron damage becomes more significant, and azotemia, which again is that accumulation of nitrogenous waste in the blood, starts to appear. Albuminuria is usually present at this point, and the patient may start to experience symptoms like fatigue or fluid retention. So managing underlying conditions like diabetes and high blood pressure becomes even more critical here. And dietary restrictions on fluid, protein, and electrolyte intake are often introduced to be able to preserve remaining kidney function. Now moving to stage 4. So in this stage, the GFR decreases even more, ranging between 15 and 29. Waste elimination becomes significantly impaired, and the symptoms of uremia, such as nausea, itching, or cognitive changes, are very common. So the kidney's ability to regulate fluid and electrolyte balance becomes severely reduced, which causes complications like hyperkalemia, metabolic acidosis, and fluid overload. At this point, preparations for renal replacement therapy, such as dialysis or even a kidney transplant, often begin. Then in stage 5, so stage 5 is classified as end-stage kidney disease or end-stage renal failure with a GFR of less than 15. So at this stage, the kidneys are no longer able to sustain life without an intervention. So waste products like urea and creatinine will accumulate to very toxic levels, and severe imbalances in fluid, electrolytes, and acid-base regulation also occur. At this stage, without renal replacement therapy or even a kidney transplant, death is going to be inevitable. Okay, so getting back into our patho review here. So there's really three big significant changes that occur in the body with chronic kidney disease. So we see abnormal urine production, we see severe fluid and electrolyte disruptions, and we see metabolic abnormalities. So keep in mind these three things that are happening in the body due to this disease process as we talk about the different changes that are occurring in the body. So starting with the kidney. So we know that chronic kidney disease is obviously going to bring about some very significant changes in kidney function and the body's overall balance. So with abnormal urine production, so initially, even as nephrons are lost, healthy nephrons can compensate by enlarging and working harder. And this allows the kidneys to maintain essential homeostasis until about 75% of kidney function is lost. However, as the disease progresses, the kidneys are going to lose the ability to dilute urine. So the urine is going to end up having a fixed osmolarity. And eventually, urine output is going to decrease because the kidneys aren't working like they're supposed to. And we'll see an increase in the blood urea nitrogen or BUN levels, which indicates that declining waste elimination. As far as fluid issues, what we see, so as CKD advances, the kidneys are no longer going to be able to excrete sodium effectively. So this leads to extracellular fluid volume overload, which puts the patient at risk for several complications like edema in the extremities, pulmonary crackles that are going to be heard on auscultation, which is evident of pulmonary edema. We see shortness of breath, which is because of the fluid that's accumulating in the lungs. And then we can also see pleural or even pericardial effusions, which are fluid accumulations around the lungs or the heart. And sometimes we can see these or we can note these in our assessment because we hear things like a friction rub during auscultation, or we notice diminished breath sounds. And then we'll also talk about some of the different metabolic abnormalities in the next few slides, but I want you guys to kind of have this in mind that CKD disrupts the body's metabolic balance. So it impacts processes like acid-base regulation, which leads to things like metabolic acidosis. And this occurs because the kidneys can't excrete hydrogen ions or reabsorb the bicarbonate effectively. So as these changes develop, patients are going to require very close monitoring and interventions tailored to their stage of chronic kidney disease. So understanding these underlying mechanisms that we've talked about helps us anticipate any complications so that we can provide effective care. So as chronic kidney disease progresses, we're going to see several metabolic abnormalities that arise due to the kidney's reduced ability to excrete waste products, regulate those electrolytes, and maintain that acid-base balance. So we're going to go over on this slide some of the different metabolic abnormalities along with some of those electrolyte disruptions. And first, we're going to talk about the disruption of urea and creatinine excretion. So kidneys are going to lose their ability to excrete creatinine and urea effectively, which leads to a buildup in the blood. Creatinine, which is derived from muscle metabolism, remains constant under normal circumstances, but in decreased kidney function, such as what we see in chronic kidney disease, we're going to have increased serum creatinine levels or increased creatinine levels in the blood. Similarly, urea, which is a byproduct of protein metabolism, accumulates in the blood, which contributes to that increased BUN level that we see. So this imbalance just indicates the declining ability of the kidneys to eliminate wastes. Now looking at some of our different electrolyte disturbances. So first, we're going to start with sodium. And in the early stages of CKD, patients are at risk for hyponatremia because fewer functional nephrons are available to reabsorb sodium. And this is also kind of compounded by the symptom of polyuria, which is increased urine production or output. And this leads to that sodium loss in the urine. Now, in the later stages, as CKD progresses, sodium retention becomes a problem. So the kidney's ability to excrete sodium decreases, and so we see a hypernatremia, which can cause high blood pressure and fluid retention. It usually presents as edema. Potassium. So potassium excretion primarily occurs in our kidneys. And as CKD progresses, the reduced urine output results in hyperkalemia or elevated potassium levels. We really see this in the later stages of CKD. And hyperkalemia is very important because it poses a very significant life-threatening risk of cardiac arrhythmias, because high potassium levels can disrupt that normal electrical conduction in the heart. Calcium and phosphorus imbalances. So in CKD, the kidneys are unable to excrete excess phosphorus, which leads to a hyperphosphatemia, or elevated phosphorus levels. And this, in turn, causes a hypocalcemia, or low calcium levels, just simply because these two electrolytes have a reciprocal relationship. Low calcium levels are going to stimulate the parathyroid glands to release parathyroid hormone, which is going to draw calcium from the bones to be able to restore that balance. And over time, this process is going to weaken bones and cause skeletal changes. And we're going to look at this a little more in depth on the next slide, so pause on that. Acid-base imbalances. So in the early stages of chronic kidney disease, the kidneys compensate for acid retention by increasing acid excretion. So as nephrons are lost, as this continues, the kidneys are not going to be able to excrete hydrogen ions, which leads to metabolic acidosis. Reduced ammonium production and diminished bicarbonate reabsorption can further contribute to this acidosis. And so what we see is a buildup of hydrogen ions, and we see a base deficit in the blood. So to compensate for this metabolic acidosis, the respiratory system is going to increase the rate and the depth of breathing, which is a pattern known as Kussmaul's respirations. And this is to help excrete or blow off that excess carbon dioxide to help maintain that pH balance. Without intervention, metabolic acidosis requires treatment with alkali replacement therapy. So all of these metabolic changes are interrelated, and they significantly impact a patient's overall health. So they really show the importance of careful monitoring and our interventions to help manage all of these different imbalances and to, again, prevent those complications that we see associated with chronic kidney disease. All right, so as promised, we're going to look a little bit deeper into this calcium and phosphorus imbalance. So the balancing between calcium and phosphorus in the body is very important, and it's tightly regulated by the kidneys, vitamin D, and parathyroid hormone. So in chronic kidney disease, this balance, as you can imagine, gets severely disrupted, leading to significant skeletal and systemic complications. So we're going to break this down step by step of what's actually occurring. So starting with our effect on phosphate. So normally, excess phosphorus is going to be excreted through the kidneys. However, in chronic kidney disease, the kidney function is reduced, and so this leads to phosphate retention. So we see a hyperphosphatemia, or too much phosphate in the blood. So these elevated phosphate levels cause phosphate to bind with calcium into the bloodstream, which leads to a decrease in our blood calcium levels. So we see a hypocalcemia. So now let's talk about the effect on calcium here. So at the same time, the kidney's ability to produce active vitamin D is also diminished. Without having that sufficient active vitamin D, calcium absorption in the GI tract is going to decrease, which is going to further lower those calcium levels. Now, in response to this low calcium level in the blood, the parathyroid glands are going to release more parathyroid hormone, and this triggers the release of calcium that is stored in the bones. This is a process known as bone resorption. So now, moving into what we see as far as skeletal and systemic implications. So while that bone resorption is going to help increase the blood calcium levels or the serum calcium levels, it comes at a cost because bone density is going to diminish. So we're going to have a loss of bone density, and we're going to start to see skeletal deformities. So over time, patients can develop conditions like osteodystrophy or fractures due to these weakened bones. So the excess calcium that's released from the bones often binds with retained phosphate, which leads to metastatic calcification in soft tissues including like blood vessels and organs, which just further complicates chronic kidney disease. So as you can see, phosphate and calcium, they have this reciprocal relationship. If one is up, the other's down. If the other is up, then the other one's down. So you can see here on the visual there on the left-hand side of your screen that seesaw relationship between calcium and phosphorus. So when phosphorus levels rise, calcium levels fall and vice versa. So this interdependence really highlights why managing both minerals is so important in patients who have chronic kidney disease. Now let's talk about a couple of clinical considerations. So interventions for this imbalance often include phosphate binders to help reduce that serum phosphate, vitamin D supplementation to help improve calcium absorption, and dietary restrictions on foods that are high in phosphorus. All right, so now let's get into the cardiac changes that we see. And cardiac complications are a leading cause of morbidity and mortality in patients with chronic kidney disease, especially in the later stages. So now we're going to look at some of the key cardiac changes that are associated with chronic kidney disease. And first, we have cardiorenal syndrome. So the kidneys and the heart have a reciprocal relationship, meaning dysfunction in one organ can cause dysfunction in the other. This is known as cardiorenal syndrome. So for example, reduced kidney function can lead to fluid overload, which increases the workload on the heart. In the same way, heart failure, which is where the heart can't pump like it's supposed to, can cause impaired renal perfusion, which worsens the kidney function. Our second complication is hypertension or high blood pressure, and this is both a cause and a result of chronic kidney disease. So chronic kidney disease is going to elevate blood pressure through sodium and fluid retention or overload, and the dysfunction of the renin-angiotensin-aldosterone system. Both of these things elevate blood pressure. So reduced kidney perfusion triggers the release of renin, which leads to the production of angiotensin and aldosterone. Angiotensin causes vasoconstriction, which raises the blood pressure, while aldosterone stimulates sodium and water retention. So you can see this creates a cycle of high blood pressure that's going to worsen kidney damage. And the resulting high blood pressure is often severe and difficult to manage, which just further contributes to that decline in kidney and heart function. Third, we have hyperlipidemia. So chronic kidney disease alters fat metabolism. And so this leads to increased levels of triglycerides, total cholesterol, and low-density lipoproteins, or LDLs. These changes significantly raise the risk of coronary artery disease and acute cardiac events. And the risk is even greater in patients who have both chronic kidney disease and diabetes, as lipid abnormalities and atherosclerosis become more pronounced. Our fourth complication is heart failure. We've kind of already talked about this a little bit. So the increased workload on the heart due to things like anemia, high blood pressure, and fluid overload often leads to heart failure. Left ventricular hypertrophy, or enlargement of the left ventricle of the heart, is very common in patients who have end-stage kidney disease, and this is due, again, to that chronic hypertension and volume overload. Also, uremia can cause uremic cardiomyopathy, where toxins can directly affect the heart muscle, which further impairs the cardiac function. A fifth complication is pericarditis. So uremic toxins or even infections can inflame the pericardial sac, which is that sac that the heart sits in, and this causes pericarditis. If it's not treated, it can lead to a pericardial effusion and cardiac tamponade, which are both life-threatening complications that we'll talk about later on. So symptoms of this, we would see things like severe chest pain, shortness of breath, tachycardia, and narrowed pulse pressure. And again, like I talked about earlier, you'd hear that pericardial friction rub heard on auscultation. And treatment for this involves the immediate removal of that fluid in the pericardial sac so that we prevent a cardiac arrest from happening. So kind of talking about this clinical significance here, kind of wrapping all this up. Cardiac complications, again, are the leading cause of death in patients with end-stage kidney disease. So early recognition and management of high blood pressure, hyperlipidemia, and heart failure are all very crucial in reducing the cardiac burden that's associated with CKD. So this requires a multidisciplinary approach, blood pressure control, lipid management, and monitoring for symptoms of cardiac decompensation. So chronic kidney disease really impacts nearly every body system, and its effects on the hematologic, the GI, and the cognitive functions are all particularly significant as well. So we're going to break these down. First, we'll talk about the hematologic and immunity changes. So anemia is a very common issue that's seen in the later stages of chronic kidney disease, and it worsens symptoms like fatigue and weakness. And anemia is caused by a decrease in erythropoietin production, which is necessary for red blood cell formation. Our kidneys help produce erythropoietin, so if they're not working well, then we have a decrease in erythropoietin, which causes that anemia. Also, we see a shortened red blood cell lifespan due to uremia, and we also see deficiencies in iron and folic acid. So you can see how anemia can be very common. It can become a pretty big issue with CKD patients. A lot of times these patients need blood transfusions. Also, with our hematologic and immunity changes, patients with CKD can also have impaired platelet function, which can lead to increased bruising or even bleeding. And CKD reduces immunity, so it makes patients more susceptible to infections. And this is because uremia disrupts the white blood cell production and function, while fluid and electrolyte imbalances can also contribute to inflammation and immune impairment. Now getting into our GI changes. So uremia affects the entire GI system. The enzyme urease in the mouth breaks down urea into ammonia, which causes halitosis, otherwise known as uremic fetor, and it also causes stomatitis, which is inflammation of the mouth. Patients can also have anorexia, nausea, vomiting, and hiccups, possibly due to this elevated BUN and creatinine levels, as well as metabolic acidosis. Peptic ulcer disease is also common, but it's not fully understood as to why patients develop PUD. Uremic colitis can also happen, which is characterized by watery diarrhea or constipation. It just can also occur. In really severe cases, GI ulcers can actually erode blood vessels, which can lead to like life-threatening GI bleeding and even hemorrhagic shock. For our cognitive and functional changes, so chronic kidney disease impacts the brain and the nervous system. So we see cognitive and physical impairments in the later stages. So patients can experience difficulty concentrating, confusion, and reduced physical capacity. Also, CKD increases the risk of drug toxicity and adverse effects because of the kidney's reduced ability to metabolize and excrete medications effectively. So if they can't get rid of the medications, it's going to have a buildup, which causes toxicity. So careful monitoring of medication regimens is also important to prevent complications. All right, so getting out of our pathophysiology review, we're going to start looking at the etiology and genetic risks that are associated with CKD, as well as its prevalence and impact. So starting with our etiology and genetic risks, so there are more than 100 different disease processes that can lead to the progressive loss of kidney function. However, the two primary causes of chronic kidney disease are high blood pressure, hypertension, and diabetes mellitus. Both conditions place significant strain on the kidneys, which leads to damage over time. It's important to also note that some populations are at higher risk. For example, African American individuals are more likely to develop end-stage kidney disease due to hypertension-related kidney damage. So recognizing these genetic and socioeconomic disparities is very important for effective prevention and treatment. Now moving on to our incidence and prevalence. So CKD affects approximately 15% of adults in the US, which is about 37 million people. However, it is a silent disease. About 9 out of 10 adults with CKD don't know that they have it. So until the later stages where they really start to have symptoms. So this shows the importance of routine screenings for those populations who are at risk. So for our clinical implications here, so understanding the underlying causes and the risk factors of CKD allows us to really focus on those preventative measures like managing blood pressure, controlling blood sugar levels, and addressing social determinants of health. So identifying CKD early can make a big difference in patient outcomes. All right, so preventing or delaying the progression of CKD involves a really proactive approach to control underlying risk factors and promote healthy lifestyle habits. So we're going to look at some of the strategies for health promotion and maintenance. And first and foremost is to control the diseases that lead to CKD. So again, diabetes and high blood pressure are the leading causes of chronic kidney disease, and effective management of these conditions is very important to prevent kidney damage. So we want to encourage patients with diabetes to maintain their blood glucose levels within that prescribed range, and we want to teach patients with high blood pressure about the importance of adhering to drug regimens that can reduce their blood pressure and minimize vessel damage. Second, we have lifestyle and dietary adjustments. So we need to possibly restrict dietary sodium, potassium, and cholesterol to help reduce the strain on the kidneys. We want to encourage weight maintenance, aiming for the BMI between 22 and 25. We want to promote smoking cessation as well as daily exercise for about 30 to 60 minutes. Really, this amount of time of moderate intensity exercise can help improve overall cardiovascular and kidney health. And also, we want to limit alcohol consumption to 1 to 2 drinks per day, and this is just to prevent additional kidney stress. Also, infection prevention and hydration. So we need to teach patients with kidney or urinary tract infections to complete their full course of antibiotics and to avoid complications. We need to recommend drinking at least 2 liters of water daily, unless the patient has fluid restrictions, which may be required by other health issues. So adequate hydration is going to help flush the kidneys and maintain that function. Also, medication safety. So we want to advise caution with NSAIDs, which can reduce blood flow to the kidneys. Also, a lot of the different NSAIDs are metabolized through the kidneys. So patients need to use the lowest effective dose for the shortest duration to minimize any potential harm. Prolonged and even high-dose NSAID use can significantly impair kidney function. And lastly, we have routine testing. So encouraging patients who have diabetes or high blood pressure to undergo yearly urine albumin to creatinine ratio testing, along with serum creatinine and BUN levels to help monitor kidney function. All right, so now let's get into our nursing assessment. So whenever we're assessing a patient for chronic kidney disease or its risk factors, a thorough nursing assessment is very important to recognize those early cues. And this involves getting a detailed history and noting any key findings that may indicate CKD. So let's go through some of these different components. So first, the patient's history. We want their age and their gender. Both are important because CKD risk increases with age, and certain conditions may have gender predispositions. We want to know their height and their weight. So we want to document the patient's usual weight and any recent changes. Weight gain can indicate fluid retention, which may be due to poor kidney function, while weight loss may result from uremia-induced anorexia. We will also want to get a history of any kidney or urologic problems. This includes any previous diagnoses, infections, or known abnormalities. We also need to get a history of any chronic health problems, so conditions like high blood pressure, diabetes, lupus, arthritis, cancer, or even tuberculosis can contribute to declining kidney function. And we also want to ask them about any drug use, any prescribed or over-the-counter medications, because a lot of these drugs are nephrotoxic. We also want to ask about any recent imaging, because CT scans with contrast can actually damage the kidneys. It's that contrast. It's very nephrotoxic. Aside from our patient's history, we need to get a family history. So we need to determine if there is a family history of kidney disease, which could suggest some genetic factors that may contribute to chronic kidney disease. We also need to ask about the patient's dietary habits. So ask about any changes in taste. Again, because CKD can alter taste perception, it can actually make sweet foods less appealing, and it may give meat more of a metallic taste. We also need to ask about the presence of any nausea, vomiting, anorexia, hiccups, diarrhea, or constipation, all of which can be the result of the accumulation of those metabolic waste products. We need to ask about the patient's energy levels. So fatigue is a very common and profound issue in CKD, especially for patients who are undergoing dialysis. We need to ask about any recent injuries, weakness, or changes in daily activities, because all these can indicate anemia or pulmonary complications. Symptoms like drowsiness or shortness of breath or bruising can suggest complications like pulmonary edema or other hematologic changes. And lastly, we need to ask about their urine elimination. So we need a detailed description of their urination patterns, including frequency, appearance, and if they're having any difficulty. Changes in urine may point to an underlying urologic problem, which can affect kidney function. All right, so moving into our physical assessment. And we know now that chronic kidney disease impacts every body system. The neurologic system is also particularly affected due to the changes in fluid and electrolyte balance, acid-base balance, and that accumulation of nitrogenous waste products. So we're going to focus this slide on the neurologic symptoms to assess. So first being cognition and alertness. So patients may have lethargy, they may have daytime drowsiness, or an inability to concentrate, all of which can indicate early stages of uremic encephalopathy. And in more severe cases, symptoms can escalate to seizures or even coma, which signal significant neurologic dysfunction. We also need to look at motor and sensory changes, so looking for things like slurred speech or difficulty coordinating movements, all of which can suggest advanced neurologic impairment. We want to assess for escherichia, which presents as a jerky or flapping of the hand movements. This is a very classic sign of uremia. Other motor abnormalities include things like tremors, twitching, or jerky movements such as myoclonus, which can often result from electrolyte imbalances. And patients can also develop ataxia or alterations in their gait, which can make mobility challenging. Third, we want to look at peripheral neuropathy. So sensory deficits often present as paresthesias, or like a feeling of like a glove or sock on the extremities. It's just more so a pattern of numbness and tingling in the hands and feet. So these symptoms result from uremic neuropathy, where nerves are damaged by these accumulated toxins. So interventions and some clinical implications to talk about here. So neurologic symptoms like encephalopathy may improve with dialysis, but some effects such as severe neuropathy can be more persistent. Depression can further compound any cognitive and neurological impairments, making a mental health assessment a really important part of our care. And emergent dialysis is often going to be required when severe neurologic functions like seizures or coma happen. And we use dialysis to help rapidly remove these accumulated toxins. We'll talk more about dialysis in a little bit. All right, moving into our cardiovascular assessment. So most symptoms are going to stem from changes in fluid and electrolyte balance, acid-base balance, and again, that buildup of nitrogenous waste. So our cardiovascular manifestations in CKD patients are often the result of fluid overload, high blood pressure, heart failure, pericarditis, and potassium-induced dysrhythmias, as well as any cholesterol or calcium deposits in the blood vessels. So whenever we're assessing for these signs, it's very important to evaluate for reduced sodium and water excretion, because untreated blood volume overload can progress to high blood pressure, pulmonary and peripheral edema, and even heart failure. So for this, we need to pay close attention to the heart rate and rhythm, noting any extra sounds such as an S3 or irregular pattern, because that can indicate fluid overload. We want to listen for a pericardial friction rub, which can indicate pericarditis. And we want to measure the blood pressure in both arms unless they have a dialysis vascular access device present. We also want to check for jugular venous distension and look for any edema in the areas like the feet, the shins, the sacrum, and around the eyes. All of these are signs of fluid accumulation or fluid overload. As well as whenever we're listening to the lungs, we want to be listening for things like crackles and noting if the patient is short of breath, especially if they're getting short of breath on exertion or even at night. Again, all of these are indicators of fluid overload. So these assessments are very important in recognizing these early cues and to help guide the appropriate interventions for these patients. All right, moving into our physical assessment of the respiratory hematologic system. We're going to start with the respiratory. So respiratory symptoms in CKD patients can be pretty distinct. You might notice that their breath has a ammonia-like odor, which is often referred to as uremic factor or uremic halitosis. They can also have deep sighing, frequent yawning, or shortness of breath. So we want to carefully observe their breathing patterns, especially the rate, the depth, and the rhythm of their breathing. Again, because we're looking for that possible Kussmaul's respirations that are a result of metabolic acidosis. And again, the metabolic acidosis, the respiratory system tries to compensate, and so we see that increased breathing rate and increased breathing depth, which is Kussmaul's respirations. Again, it's just signaling the body's attempt to compensate for that severe acidosis. Some patients may also present with pneumonitis or a uremic lung, where you'll need to assess for symptoms like thick sputum, reduced coughing, fever, and tachypnea. And again, always remember to auscultate the lungs for crackles, which could indicate fluid overload. Moving into our hematologic symptoms of CKD. So we already talked a little bit about this. We're going to see symptoms of anemia and abnormal bleeding. So whenever we're assessing for anemia, we're looking for signs of fatigue, pallor, lethargy, weakness, and shortness of breath. That's because these symptoms are due to reduced red blood cell production, which is, again, a very common complication. Abnormal bleeding can manifest as bruising, petechiae, purpura, and mucosal bleeding in the gums or in the nose, or even GI bleeding, where we see bloody stools like melena, which are black tarry stools, or even we can see frank red blood. So it's very important that we have careful observation and documentation of all of these signs, which are very important so that we can have early intervention and we can have effective patient management. All right, so continuing in our physical exam, so starting with the GI system. So patients with CKD often experience halitosis, which is that foul-smelling breath that you've heard me mention a few times, and this is due to the buildup of toxins in the body. Also, inflammation or ulceration in the mouth can also occur, so we want to be sure to assess for any signs of these conditions. And we need to document whether or not the patient has complaints of abdominal pain, cramping, or vomiting, because all of these can indicate GI complications as well. And finally, testing stool for occult blood is a big part of our assessment because GI bleeding is a potential concern for these patients. Moving on to our skeletal symptoms. So these are typically related to osteodystrophy, which is a condition that's caused by poor calcium absorption and continuous bone calcium loss. Remember we talked about earlier that relationship with calcium and phosphorus and what we see with that. So patients who have osteodystrophy will have thin, fragile bones, which increases their risk of fractures even with minimal trauma. It's also common for vertebrae to become more compact, which leads to a forward bend in these patients' posture and a noticeable loss of their height. So during the assessment, we want to ask about changes in height as well as ask if they're having any bone pain. We need to observe for any spinal curvatures or unusual bumps and protrusions, which could indicate a fracture. It's also important to handle these patients with extra care during our physical exams, as well as daily care activities to avoid causing any further injuries. Moving on to our physical assessment of urine and skin symptoms. So first we're going to talk about our urine symptoms. And these symptoms directly reflect the kidney's decreased ability to function. So as CKD progresses, patients may notice changes in the amount, the frequency, and the appearance of their urine. So for example, urine in mild to moderate CKD may appear more dilute and it may be clearer. This is just due to that reduced resorption of water. However, as kidney function declines, severe CKD or even end-stage kidney disease, we may see oliguria, which is a significantly reduced urine output. This becomes a lot more common as the disease progresses. However, it's also important to note that not all patients are going to experience the same urine output. Some may still produce over a liter of urine daily, even in advanced stages. So that's why it's really important to monitor urine volume as well as any changes in the urine appearance, which may include protein, sediment, or even blood. Extended periods of oliguria typically suggest that the kidney recovery is not likely, especially in your end-stage diseases. So now let's move on to the skin. So skin symptoms in CKD are primarily a result of uremia, which leads to pigment deposits that cause a yellowish discoloration or a brown or bronze darkening, especially in your darker skinned patients. Anemia further contributes to a pale, even like a faded suntan-like appearance in your lighter skin individuals. Skin oils and turgor are often going to be reduced, which leads to dryness, which can exacerbate symptoms of severe pruritus or itching. A lot of patients with CKD experience this. In advanced stages, uremic frost, which is a visible layer of urea crystals from evaporated sweat, can appear on the face, the eyebrows, the axilla, and the groin. And lastly, we want to assess the skin for any signs of bruising, purpura, and rashes. These findings can indicate underlying bleeding tendencies or other complications that are associated with chronic kidney disease. So a thorough assessment of these symptoms is very important for identifying issues early and ensuring effective patient care. All right, so the last part of our nursing assessment, we're going to discuss the lab and imaging assessments that are used in chronic kidney disease. So starting with our lab assessments. So with CKD, we see significant changes in a variety of lab values. So careful monitoring is very important. For our blood tests, we need to assess the creatinine and the BUN. We also need to look at electrolytes like sodium, potassium, calcium, phosphorus, and bicarbonate. As well as we need to look at hemoglobin and hematocrit levels, and we've discussed how all of these different things can be impacted through our patho review. We also need to get a glomerular filtration rate, or GFR, because these trends are very important for understanding the kidney function over time. We also need to get a urinalysis. This is another key diagnostic tool. So in the early stages of CKD, a urinalysis might reveal the presence of protein, glucose, red and white blood cells, and changes in specific gravity. So urine osmolarity may initially decrease, but it's going to tend to increase as CKD progresses and the urine output diminishes. Also, the urine albumin to creatinine ratio can also provide some pretty good insight into the kidney damage and the overall function of kidneys as well. Moving on to our imaging assessments. So these are oftentimes used to rule out structure abnormalities or obstructions. So we see diagnostic procedures like a cystoscopy, a retrograde pyelography, or even a kidney biopsy to look closer at some of these specific issues. So for imaging, we also have options like a kidney ultrasound, a KUB x-ray, which is kidneys, ureters, and bladder, and we can also utilize CTs or MRI scans. These just help to identify any changes such as renal atrophy or fibrosis, which are very common in advanced CKD. In end-stage kidney disease, the kidneys may shrink to 8 or 9 centimeters in size, which just reflects the extent of the damage. However, keep in mind that imaging findings may be limited in the earlier stages of CKD. All right, so now let's talk about our nursing process of how we are going to analyze cues and prioritize hypotheses for patients with chronic kidney disease. So our first problem to address is going to be fluid overload, which occurs again due to the inability of the diseased kidneys to maintain that proper fluid balance in the body. So we see complications like edema, high blood pressure, and pulmonary congestion, which makes this a very critical issue to manage. Next, we have decreased cardiac function, which is often the result of reduced stroke volume, dysrhythmias, fluid overload, and increased peripheral vascular resistance. So this combination places significant strain on the cardiovascular system, which increases the risk of heart failure and other complications. Our third problem is weight loss. So this may result from the patient's inability to ingest, digest, or absorb food and nutrients due to the physiologic factors that are associated with CKD. This often contributes to malnutrition and weakened immunity. And our fourth concern is the potential for injury. So kidney disease affects bone density, as we know. It also affects blood clotting and drug elimination, which leaves patients at a higher risk for fractures, for bleeding, and for adverse drug reactions and toxicity. And finally, we need to consider the potential for psychosocial compromise. So patients with CKD, they often have a big impact on their mental and their emotional well-being. Factors like chronic fatigue, changes in lifestyle, and the burden of ongoing treatments can really contribute to anxiety, depression, and social withdrawal. So by prioritizing all of these hypotheses, we can focus on the most critical issues first, ensuring that we get the best care for these patients. All right, so now we're going to move into our planning and implementation. And we're going to start with this slide looking at how we can manage that first prioritized problem, which was fluid overload. So we're going to talk about how we can manage this. And it's very important for effective fluid management because it helps us to maintain an acceptable balance and so that we can prevent complications like pulmonary edema. So let's begin with our daily weight monitoring. And this is one of the most reliable indicators of fluid retention in our chronic kidney disease patients. A gain of 1 kilogram of weight is equivalent to approximately 1 liter of retained fluid. To ensure accuracy, we need to be sure to weigh the patient at the same time each day, using the same scale and with the same clothing, and preferably after they've voided if that's possible. Tracking weight trends is critical for evaluating the effectiveness of our interventions and to identify any potential issues. Next, we'll focus on measuring fluid intake and output accurately. So this includes oral, IV, and enteral sources of fluids. We need to teach both the patient and their family about prescribed fluid restrictions and emphasize the importance of evenly distributing fluid intake over a 24-hour period to help manage thirst and maintain comfort. Now let's discuss monitoring for fluid overload symptoms, and this is very important. So symptoms of fluid overload may include decreased urine output, a rapid and bounding pulse, shallow respirations, dependent edema, crackles or wheezing heard upon lung auscultation, distended neck veins, decreased oxygen saturation, and an elevated blood pressure with a narrowed pulse pressure. We want to be sure to assess all of these indicators every 4 hours, especially in our unstable patients, so that we can catch those early signs of deterioration. When it comes to medication management, diuretics like furosemide or butanide can be prescribed for patients with mild to moderate CKD who still produce urine. So these drugs help to increase urinary elimination of fluid, which reduces both fluid overload and high blood pressure. However, patients with end-stage kidney disease, in these patients, diuretics is going to be generally avoided as kidney function is significantly reduced. Therefore, these drugs will just accumulate in the body, potentially causing harm, including more damage to the kidneys and hearing loss, which is a side effect of furosemide. For patients who require dialysis, fluid management becomes even more important. So hemodialysis is often performed 3 to 4 times a week for about 3 to 4 hours per session. Some patients may opt for peritoneal dialysis, but we're going to talk about both of these forms of dialysis here in just a few slides. But either way, we want to monitor their weight carefully before and after dialysis to be able to assess for the effectiveness of fluid removal. Now lastly, let's talk about preventing pulmonary edema, which is a very severe complication resulting from fluid overload or even left-sided heart failure. So pulmonary edema occurs when increased pressure in the pulmonary vessels causes fluid to leak into the lung tissue and alveoli. So early signs include restlessness, anxiety, shortness of breath, rapid heart rate, and crackles at the lung bases. And as the condition worsens, patients can get a frothy, blood-tinged sputum, cyanosis, and diaphoresis. Immediate action is needed to prevent further respiratory and cardiac decline. So by implementing all of these strategies we just talked about, daily weight monitoring, accurate fluid measurements, patient and family education, and vigilant symptom assessment, nurses can effectively manage fluid volume in CKD patients and significantly reduce complications. All right, moving on to our planning and implementation interventions to improve cardiac function. So we're going to start with blood pressure control, which is essential for preserving kidney function, especially in patients with long-standing high blood pressure, which is, again, a significant risk factor for CKD progression. A variety of medications may be prescribed to help achieve this goal. We can use diuretics like thiazides to help manage fluid overload. Calcium channel blockers can help improve glomerular filtration rate and renal blood flow. ACE inhibitors are particularly effective in reducing cardiovascular events and slowing kidney damage in patients with CKD and high blood pressure. Alpha adrenergic and beta adrenergic blockers work by reducing heart rate and blood pressure. And vasodilators can lower vascular resistance to reduce blood pressure further. So we want to teach patients and their families how to measure their blood pressure daily and to record their readings. We need to regularly evaluate their technique to make sure they're doing it correctly. Also, we need to educate them on the relationship between blood pressure control, diet, and prescribed medications. We need to encourage them to bring records of their blood pressure, their medication times, and their weights to their healthcare appointments for ongoing assessments, and so that we can adjust their care plan if needed. Now let's talk about promoting cardiac output, especially in patients with signs of reduced heart function. So digoxin is a medication that may be prescribed to help improve contractility and help promote cardiac output. However, this medication requires very close monitoring. We need to regularly assess the serum digoxin and potassium levels to reduce the risk of toxicity, because electrolyte imbalances and kidney impairment can likely increase the event of an adverse event. Finally, we want to continuously monitor patients for signs of reduced cardiac output, heart failure, and for dysrhythmias. So symptoms like fatigue, shortness of breath, peripheral edema, and irregular heart rhythms all can indicate declining cardiac function, which requires immediate intervention. All right, now let's talk about how we can enhance nutrition for patients with CKD. Proper nutritional management is very important for preventing malnutrition, slowing disease progression, and to avoid complications like uremia and electrolyte imbalances. So the first step in optimizing nutrition is a referral to a registered dietitian nutritionist. For patients with a GFR below 50, this is a Medicare covered service, and it's an essential component of their care. The RDN can collaborate with the healthcare team to create an individualized nutrition plan, helping patients navigate the necessary dietary changes they need. So these plans often include protein control, fluid restrictions, electrolyte imbalance, and adequate calorie intake. So let's talk about protein intake control and why that's so important. So protein breakdown contributes to the buildup of waste products, which is the primary cause of uremia in CKD. Therefore, protein intake needs to be tailored based on the patient's GFR and their treatment stage. So for patients with a GFR below 30, intake should be limited to about 0.8 grams per kilogram per day. However, patients who are on dialysis, they may need a higher protein intake, being 1 to 1.3 grams per kilogram per day. And that's just necessary to compensate for the losses of protein during treatment with dialysis. Dietary protein should come from high-quality sources, so like lean meats and eggs. We also need to monitor serum prealbumin and the BUN levels to help evaluate whether protein intake is sufficient or if it's excessive. Inadequate protein can lead to muscle wasting, while excess protein can worsen uremia. Now let's talk about fluid intake limitation, and this is just as important, especially for patients with reduced or no urine output. So excess fluid can cause edema, high blood pressure, and heart failure. And for those not on dialysis, fluid intake is going to be oftentimes restricted to 500 to 700 milliliters per day, plus any urine output that they have. So sodium intake is also going to be limited, 1 to 3 grams daily for non-dialysis patients, and 2 to 4 grams daily for dialysis patients. Excess sodium will worsen fluid retention, and it can contribute to complications like high blood pressure. So we need to educate patients to avoid high sodium foods, such as processed meats, fast foods, and salty snacks, and teaching them to avoid adding salt to meals is very, very important. Now for potassium and phosphorus restrictions. These just help to prevent serious complications. So elevated potassium levels can lead to life-threatening cardiac dysrhythmias. Patients need to limit their potassium intake to 60 to 70 milliequivalents daily, and they need to avoid any potassium-based salt substitutes. Foods that are high in potassium, like bananas, oranges, and tomatoes, need to be avoided, while low potassium alternatives are encouraged. Phosphorus restriction is also important to prevent renal osteodystrophy. So high phosphorus foods like dairy products, nuts, and beans need to be limited, and phosphate binders like calcium carbonate should be taken with meals to prevent that phosphorus absorption. Now let's talk about vitamin and mineral supplementation to address deficiencies that are common in CKD. So anemia, due to that decreased erythropoietin production and a limited dietary iron, is treated with ferrous sulfate supplements and medications like epoetin alpha. Patients also require vitamin D and calcium supplements to help support bone health and to counteract the effects of that phosphorus imbalance. And finally, sufficient calorie intake is very important to meet the metabolic needs of the body without relying on excessive protein. So by providing adequate calories, we prevent muscle wasting and we support energy levels. So it's very important that we collaborate with the patient to identify calorie sources that fit within their dietary restrictions. All right, now let's discuss how we can prevent injuries in patients with CKD. So patients with long-standing CKD are at increased risk for fractures, drug-related toxicity, and infection due to bone fragility, altered metabolism, and compromised immunity. Therefore, preventing injury is very important to maintain quality of life and to avoid any further complications. So let's start with injury prevention strategies related to fragile bones. So CKD, as we know, can lead to renal osteodystrophy, again, a condition that causes brittle, fragile bones that are very prone to fractures. So whenever we're moving or repositioning a patient, we always want to use a lift sheet rather than pulling to minimize the stress on their bones. So with this, we need to teach any assistive personnel to use the lift sheets correctly. Also, observe for any abnormal range of motion in joints and look for any unusual bumps, depressions, or tenderness over bony areas that could indicate fractures or a deformity. Managing drug therapy is another important aspect of injury prevention. So patients with CKD are particularly vulnerable to drug toxicity because their reduced kidney function impairs the elimination of a lot of medications. So we want to begin with a detailed drug history to identify any nephrotoxic drugs, including certain antibiotics, NSAIDs, ACE inhibitors, angiotensin receptor blockers, and IV contrast dye, which should generally be avoided or used very cautiously. So we need to regularly consult with the healthcare team to adjust drug dosages based on the patient's kidney function. So with this, we want to monitor for signs of drug toxicity. So for example, opioids can cause prolonged respiratory depression in patients with CKD due to that delayed metabolism. And insulin doses often need to be reduced because the kidneys can't effectively excrete these drugs, which can increase the risk for hypoglycemia. Regular blood glucose monitoring is very important in patients with diabetes because of this. And we need to educate patients to avoid any antacids that contain magnesium because CKD limits magnesium excretion, which can also lead to toxicity. Phosphate binders. So these are medications like calcium carbonate, and they play a very important role in preventing renal osteodystrophy by controlling the phosphorus levels. However, these drugs can also lead to complications like hypophosphatemia or hypercalcemia if not monitored carefully. So we want to teach patients to avoid any aluminum-based phosphate binders due to the risk of bone disease and neurologic complications from prolonged use. So we're going to monitor for symptoms like muscle weakness, anorexia, bone pain, and tremors, all of which can indicate these imbalances. Preventing infection is another priority, especially in patients who are undergoing dialysis. So dialysis patients will have a vascular access device, and those who are doing peritoneal dialysis will have a catheter site. We'll talk about this a little bit later on, but we need to inspect these sites every shift looking for signs of infection, redness, swelling, pain, or drainage. Sometimes prophylactic antibiotics are needed before dental procedures to just help reduce the risk of bloodstream infections that may be caused by oral bacteria. However, antibiotics, for the most part, are used very cautiously in CKD patients. We need to be careful to ensure the appropriate dose adjustments for any medications that may be nephrotoxic. And finally, we need to monitor patients who are receiving anticoagulant therapy, because again, poor platelet function and capillary fragility in CKD increase the risk of bleeding. So we're going to regularly assess for bleeding, bruising, or changes in coagulation markers, and we're going to adjust therapy as needed to balance efficacy with safety. So by addressing all of these areas, bone fragility, drug safety, phosphorus control, infection prevention, and anticoagulant monitoring, we as nurses play a pretty big role in preventing injuries and complications in our CKD patients. So it's through careful observation, education, and collaboration that we can significantly enhance our patients' outcomes and their safety. All right, for our last planning and implementation slide, we're going to focus on how we can minimize psychosocial compromise in our patients with CKD. So again, the chronic nature of CKD and its impact on daily life can have a big impact on a patient's mental and emotional well-being. So some common psychosocial challenges that we see are anxiety, depression, social isolation, and fatigue. So addressing these issues is essential to improving overall quality of life and adherence to treatment. So first we'll talk about anxiety and depression. So these are very prevalent among CKD patients. Many experience profound feelings of loss, such as changes in work or family roles, all of which can contribute to depression. And depression is closely linked to poor treatment adherence, further complicating disease management. Also, sleep disturbances are very common, especially in patients who are undergoing dialysis, and this can exacerbate their feelings of fatigue as well as despair. So our goal is to reduce anxiety and depression, conserve energy, and minimize the psychosocial impacts of CKD. So let's talk about interventions and how they begin with our ongoing assessment. So we're going to regularly evaluate our patients' fatigue levels, anxiety, and sleep patterns. We're going to ask about the quality of their sleep and if they're having any difficulties. We'll assess their coping mechanisms, identify which strategies have been successful in the past. We're also going to monitor or observe for behavior for cues that might indicate increased anxiety, so things like facial tension, restlessness, foot tapping, or a withdrawn posture. And then we're going to provide the timely interventions needed to help reduce anxiety levels. We also need to evaluate the patient's family and social networks and involve them in their plan of care whenever that's possible. Social systems or support systems are very important. So family involvement not only improves emotional support, but it can also enhance adherence to treatments and it can promote better outcomes. So we want to encourage patients to lean on those support systems, especially during challenging times. Fatigue management is another essential focus. So again, fatigue in CKD is often caused by anemia, vitamin deficiencies, and that buildup of urea in the blood. So treatment can include vitamin and mineral supplements because again, these patients often face dietary restrictions and therefore they can have vitamin losses that way. And if they're on dialysis, they can have vitamin losses through dialysis. However, we need to avoid administering these supplements just before a patient has hemodialysis because sometimes they can be just dialyzed right back out of the body, which reduces the supplement effectiveness. For anemia, there are some agents that stimulate red blood cell production that can help with the goal of maintaining a hemoglobin level around 10. So adequate iron stores are necessary for this therapy to be effective, so iron supplementation may also be required. Patients often report improved energy levels, appetite, and sexual function with this treatment. However, therapy can also raise blood pressure and require additional education on dietary restrictions to prevent complications. So patient education and trust building are key to reducing anxiety and empowering these patients. So we need to explain all procedures, tests, and treatments clearly using materials that match the patient's comprehension level. So consistency in care is what's going to build a trusting relationship. It's going to help enable patients to openly discuss their concerns, their fears, and their feelings about their diagnosis and their treatment plan. So we want to encourage patients to ask questions and involve family members in discussions about lifestyle changes and their prognosis. Also, community resources can also support independence and reduce psychosocial stress. So identify options like meal delivery services, transportation, and financial assistance programs to help ease the burden of CKD management. Also, while some pharmacologic treatments for depression are commonly used in the general population, patients with CKD may require additional monitoring due to that altered drug metabolism and the potential for drug-to-drug interactions. So we need to be sure we coordinate care across all healthcare teams to ensure that safe and effective management of depression and anxiety. All right, so now let's move into dialysis or kidney replacement therapies, which are critical during the advanced stages of CKD, especially in stages 4 and really in stage 5. So at this point, the pathologic changes that are associated with CKD are posing significant health risk or discomfort that can no longer be effectively managed with our conservative approaches like dietary modifications, drug therapy, or fluid restrictions. And when this happens, dialysis or even sometimes a kidney transplant may be necessary. So we're going to start with our functions of dialysis. So dialysis is designed to mimic the key functions of healthy kidneys. It rids the body of excess fluids and electrolytes, it helps achieve acid-base balance, and it eliminates the waste products that accumulate due to that impaired kidney function. This process also helps restore internal homeostasis by utilizing mechanisms like osmosis, diffusion, and ultrafiltration. So moving on to the types of dialysis. So hemodialysis is the most common form, and it can be performed intermittently, which is the 3 to 4 times a week, usually for 3 to 4 hours at a time. Or we can also have continuous renal replacement therapy. And this is for very critical patients. This is kind of done usually in ICU settings, and instead of someone getting hemodialysis intermittently, every few days for a few hours, this actually can continue for days. And this is typically reserved for those patients who are, again, very, very sick, and they cannot withstand the fluctuations in fluid, like they're not hemodynamically stable enough to go through the normal intermittent dialysis. This is used, again, for really serious things like if someone's got acute kidney problems that intermittent dialysis isn't going to fix. Another option is peritoneal dialysis, and this is where we use the peritoneal membrane to filter waste and excess fluids. And we'll talk about each one of these a little bit deeper on the next few slides. So now let's talk about when dialysis is indicated. So chronic or maintenance dialysis is recommended for patients with advanced CKD or end-stage renal disease under these conditions. The presence of uremic signs and symptoms that affect multiple body systems like nausea, vomiting, severe anorexia, lethargy, and mental confusion. It's also indicated with persistent hyperkalemia that poses life-threatening risks. Fluid overload that is unresponsive to diuretics or fluid restrictions. And lastly, a general decline in the well-being or the development of a pericardial friction rub, which again is known as uremic pericarditis. All of those are indications for dialysis. So in summary here, kidney replacement therapy is vital for patients with CKD whenever our conservative treatments are no longer sufficient. So dialysis not only prolongs life, but it also improves the quality of life by mitigating the severe symptoms that are associated with kidney failure. All right, so now we're going to focus on hemodialysis, which is the most common form of kidney replacement therapy. So the primary objective of hemodialysis is to extract toxic nitrogenous substances from the blood while removing excess fluid. So this is achieved through the use of a dialyzer, which is often referred to as an artificial kidney. So the dialyzer consists of a synthetic semi-permeable membrane that filters the patient's blood. Blood containing toxins and waste products is diverted from the patient through a pump to the dialyzer, where it undergoes filtration. Then once clean, the blood is returned to the patient, ensuring the removal of those uremic wastes and that excess fluid. So a hemodialysis requires a vascular access device. And this is established through either a central venous catheter, which is typically just used for short-term or emergency access. What you're mostly going to see for your chronic dialysis patients is either a arteriovenous fistula, which is created by connecting an artery to a vein. It provides a very durable and efficient site for that long-term access. Or patients may have a arteriovenous graft. And this is an alternative for patients whose veins are not suitable for that fistula creation. So this involves inserting a synthetic tube to connect the artery and the vein. So in terms of frequency, intermittent hemodialysis is commonly performed 3 times a week, each with a session lasting between 3 and 4 hours. This schedule allows for effective management of fluid, electrolytes, and waste products, which ensures the patient's stability between their sessions. All right, so now we're just going to dive a little bit deeper into the different types of vascular access that's used for hemodialysis. We have arteriovenous fistulas, arteriovenous grafts, and those central venous catheters. So we're going to start by talking about the arteriovenous fistulas, and these are considered the best option for long-term dialysis access. They're created by surgically connecting an artery to a vein, often in the patient's arm. So over time, the increased blood flow from the artery is going to strengthen the vein wall, which allows the patient to handle the high blood flow that's required for dialysis, or allowing their vein to handle the high blood flow. So once this fistula has matured, it can take several months sometimes, then the fistula can provide a durable and reliable access point with a lower risk of infection and clotting as compared to some of the other options. So now we'll talk about an arteriovenous graft. And again, this is typically used when a patient's vein isn't suitable for a fistula. So a synthetic material is going to be inserted to bridge the artery and the vein. Grafts are quicker to use, they're typically ready within a few weeks, but they come with a higher risk of infection and clot formation. And they also tend to have a shorter lifespan compared to fistulas, where they can only last about 3 to 5 years. So finally, dialysis catheters. And again, these are used as temporary access. They're inserted into large veins like the internal jugular or the subclavian. And while they allow for immediate use, they again are not going to be ideal for long-term dialysis simply because they have a higher risk of infection, thrombosis, and they have a shorter lifespan. So let's talk about some of the precautions needed to care for a fistula or graft. So it's important to take proper precautions for these access devices to help maintain their functionality and to reduce complications. So whenever we're caring for a patient with a fistula or a graft, we always want to assess the circulation in the lower arm by checking the distal pulses and the cap refill. We can also assess the site to make sure that the graft or fistula is working. So we can palpate the site for a thrill, which feels like a vibration, and we can auscultate for a bruit, which is a whooshing noise. And these just indicate proper blood flow through that access point. And remember, we never want to take a blood pressure, do any blood draws, or place any IV lines in the limb with the fistula or a graft, just to avoid damaging the site. All right, now let's get into complications and management. So while AV fistulas and grafts are essential for hemodialysis, they can develop complications, again, like thrombosis, infection, and even an aneurysm. So thrombosis, or blood clotting, is the most common issue. If a clot forms, it can oftentimes be easily dissolved with medications or treated with a procedure like a balloon angioplasty. Infections, which are primarily caused by bacteria like Staphylococcus aureus, can occur during cannulation, whenever we access the device. So it's important that we always follow strict aseptic technique whenever we're handling an access device. And aneurysm. So these can form from repeated needle punctures at the same site. And if large, they can compromise the access point and require surgical intervention. So for patients with arteriovenous access, it's also important to monitor for signs of ischemia or poor circulation below the site. So this can cause symptoms like cold fingers or numbness, and in severe cases, the fistula may need to be surgically revised to help improve blood flow. All right, now let's focus on post-hemodialysis care. So effective post-care ensures patient safety, and it helps prevent complications that are associated with this life-sustaining therapy. So after a hemodialysis session, it's important to closely monitor the patient for any side effects or complications, including things like hypotension, nausea, vomiting, headache, dizziness, and muscle cramps. And all of these are often due to that rapid removal of fluid and electrolytes. We always want to compare the patient's post-dialysis vital signs and their weight with the pre-dialysis measurements. So typically, blood pressure and weight are going to be decreased as fluid is removed during dialysis. If the hypotension is significant, then it may require rehydration with IV fluids such as normal saline, and usually it's just a small bolus. Also, the patient's temperature might be slightly elevated due to that warm dialysate, But if a fever is present, then sepsis needs to be suspected and a blood culture is warranted. One key post-care intervention is going to be monitoring for complications like dialysis disequilibrium syndrome. And this condition is the result of rapid shifts in fluid and electrolytes, and it can present as mental status changes, nausea, headaches, or even seizures. Another potential issue is cardiac events, which are oftentimes linked to underlying cardiovascular disease. So patients need to be evaluated for signs of new onset myocardial ischemia or pericardial complications. Lastly, we need to ensure that we check for signs of bleeding at the vascular access site, as well as any other invasive procedure site. So remember, the use of heparin that's used during dialysis increases the risk of hemorrhage, and we use heparin in dialysis just to prevent clots from happening. So we also need to teach the patient that invasive procedures need to be avoided for 4 to 6 hours after dialysis. So by carefully assessing for these complications and providing these interventions, we can improve patient outcomes and we can support their recovery post-dialysis. All right, for our last slide here, we're going to discuss peritoneal dialysis. And this is an alternative to hemodialysis to help manage that advanced chronic kidney disease. Peritoneal dialysis allows for the exchange of waste, fluids, and electrolytes directly in the peritoneal cavity using the peritoneal membrane as a natural filter. So unlike hemodialysis, peritoneal dialysis is slower and it requires more time to achieve similar results. It does have some disadvantages, including protein loss through the dialysate, and risk for peritoneal injury like peritonitis, and potential discomfort from the indwelling fluid. So despite these though, peritoneal dialysis does have some significant flexibility, making it a preferred option for patients who are hemodynamically unstable, as well as older adults or those who have issues with vascular access. So the procedure for peritoneal dialysis involves surgically placing a silicone catheter into the abdominal cavity. So each PD cycle is referred to as an exchange, and it consists of 3 steps. First is the fill stage. So dialysate, typically 1 to 2 liters, is going to be infused into the peritoneal space over 10 to 20 minutes. Then the second step is the dwell phase. So this is where the fluid remains in the cavity for a prescribed time, allowing the exchange of waste and electrolytes. And lastly, we have the drain or outflow phase. The fluid, which now contains waste, is going to be drained out by gravity into a collection bag. The drained out fluid, or peritoneal effluent, should appear clear to light yellow. Any brown or cloudy outflow should be raising flags for infection or even a complication like peritonitis. So the dialysis process relies on diffusion and osmosis, using the peritoneal membrane's large, porous surface to help remove waste products from fluid and fluid from the blood into the dialysate. So additives like heparin, potassium, or antibiotics may be included in the dialysate. It just kind of depends on the patient's needs. For example, heparin just helps prevent catheter clotting, while antibiotics are added when peritonitis is suspected. It's important to note that complications such as peritonitis, pain during dialysate inflow, and poor dialysate outflow can all occur. Peritonitis is the most common complication, often results from connection site contamination, which really emphasizes the need for that meticulous sterile technique whenever we're providing care. Also, to address poor dialysate flow, interventions like managing constipation and adjusting the patient's position are usually effective. So peritoneal dialysis offers several modes, including continuous ambulatory peritoneal dialysis and automated peritoneal dialysis. And really, the choice between these options depend on the patient's lifestyle, their abilities, and their medical needs. So nurses play a pretty big role in educating patients about proper catheter care, monitoring for complications, and ensuring effective treatment. So by doing so, we help our patients achieve the best possible outcomes with this therapy. And that is all I have for this lecture. See you guys in class.